Hello, everyone. My name is Anisha Mehta. Welcome to my presentation on the 2014 to 2016 West Africa Ebola virus disease outbreak. Over the next several minutes, I'll walk you through the trajectory, science, and human story behind the deadliest Ebola outbreak in history. This presentation is rooted in over 15 peer-reviewed sources, as well as official documentation from the World Health Organization, the CDC, and the MSF. So the Ebola virus disease, or the EVD, is caused by the Zaire Ebola virus, a member of the Filoviridae family. This pathogen is infamous for its ability to cause severe hemorrhagic fever with a high mortality rate. Ebola likely originated from zoonotic spillover, with fruit bats considered a primary reservoir. And in this outbreak, the virus was first recognized in December 2013 in Guinea and declared over in March 2016. It rapidly overwhelmed communities and health systems due to delayed recognition and weak infrastructure. Symptoms like fever, fatigue, vomiting, and bleeding confused diagnosis early on. And the image shown in over here is an electron micrograph of the virus from the CDC. Importantly, the early spread was silent due to the vague initial symptoms and the fact that early deaths occurred in remote villages without formal reporting systems. This delay allowed the virus to establish a foothold in communities before international attention was directed to the region. So the outbreak began in Guinea and quickly spread to Liberia and Sierra Leone, countries with porous borders and high regional migration. Infected travelers also carried the virus to Nigeria, Mali, the US, UK, and Spain, though these cases were largely contained. This 2015 ResearchGate map shows the virus's rapid spread across West Africa. Airports, border crossings, and frequent travel, especially during holidays and market days, complicated containment. Urbanization introduced new transmission dynamics not seen in earlier rural outbreaks. So the timeline of the outbreak starts with the index case in December 2013, but it actually was not recognized as Ebola until March 2014, like it is stated in the CDC's timeline I have pasted here. And by August, the World Health Organization declared it as a public health emergency of international concern. Liberia was declared Ebola-free in January 2016, followed by Sierra Leone and Guinea. And delayed declaration meant fewer resources, slower diagnostic support, and a steeper learning curve in understanding the outbreak scale. Surveillance gaps and poor data collection made it difficult to build epidemic curves early on. And these delays also gave the virus time to spread across borders undetected, emphasizing the need for stronger global surveillance infrastructure. So the index case was an 18-month-old boy in Milanado, Guinea, and they were initially misdiagnosed with cholera or Lassa fever due to the vague symptoms. And the virus spread very quickly due to caregiving customs and lack of PPE. And samples were eventually tested in international labs. And a photo from the MSF, which I have pasted here, shows his village, which is known as the ground zero of the outbreak. The delayed diagnosis highlights the need for rapid testing in rural areas. His story underscores how ignoring emerging syndromes in low resource settings can lead to exponential outbreak growth, reinforcing the call for stronger community level detection. So EVD spreads through direct contact with blood, secretions, and contaminated surfaces. High-risk situations include caregiving, funerals, and inadequate PPE. Incubation ranges from 2 to 21 days, and this CDC infographic here highlights key transmission routes. So traditional funerals, especially handling corpses, remained a major vector until safer burial practices were adopted. And deep-rooted rituals like washing and embracing the dead pose cultural barriers. Public health terms teams had to balance infection control with respect for tradition, working closely with elders and spiritual leaders, one of the outbreak's greatest containment challenges. So the R naught during the outbreak ranged from 1.5 to 2.5. In some districts, attack rates exceeded 3%. Health misinformation, distrust of authorities, and healthcare work shortages contributed to increased population susceptibility. Additionally, fear of being quarantined discouraged people from reporting symptoms. Rumors spread that hospitals were sites of death, further inhibiting compliance with surveillance systems and delaying intervention. And as you can see over here, I have pasted a few graphs from ResearchGate that depict an estimate of the cases and deaths for each country. Um, yeah, and as you can see, it seems that Liberia is the steepest one. And the other ones are also pretty steep, but not as much of a higher slope as Liberia. So cases were classified as suspected, probable, or confirmed, and confirmation required RT-PCR or ELISA testing. And the procedure I have pasted below, that's how RT-PCR is done. And overwhelmed labs cause delays, especially at the outbreak's peak. And symptoms include hemorrhage, vomiting, fever, and fatigue. And rural clinics often lacked trained staff and safe support, leading to days-long gaps between sample collection and confirmation. Diagnostic delays hindered isolation and treatment, making lab infrastructure a critical weakness in the response. So, certain populations were disproportionately affected, and these included frontline health workers, family caregivers, and traditional burial workers. And children and the elderly experienced higher mortality. The nature of caregiving in West Africa, whether it's personal, intimate, or physical, put these groups at unique risk. And entire families were often infected in a single household cluster. And frontline health workers not only became infected, but also suffered immense psychological trauma due to the intensity and hopelessness of care during the peak. And these exposures also depleted the healthcare workforce, making recovery even more difficult. So by mid-2014, many Ebola treatment units, or ETUs, were overwhelmed. And this is a picture of an ETU. So pretty much delayed detection led to late-stage hospitalizations, often too late to save lives. And most deaths occurred at home. And MSF's Monrovia Center became a key hub, but data remained incomplete due to system overload. Fragile health systems collapsed, leaving patients with other conditions like malaria or childbirth complications without care. And the crisis exposed the limits of vertical disease responses and highlighted the need for stronger, more resilient health systems. So by the end of the outbreak, there were over 28,000 reported cases and more than 11,000 deaths, according to the World Health Organization data. The case fatality rate averaged around 40%, though it fluctuated from 25% to as high as 90% in localized clusters. And mortality was highest in communities without access to treatment or isolation centers. And a Health Organization case death trend graph illustrates these fluctuations with steep rises during peaks in 2014 and early 2015. This graph was adapted from the World Health Organization, but I got it from the Forbes article. So the high fatality rate was not only due to the virus's virulence, but also because of systemic delays in care and shortage of basic treatment supplies like IV fluids and oral rehydration salts. In some areas, entire households perished without ever reaching a health facility. So Ebola disrupted daily life, Schools were closed, productivity dropped, and survivors faced stigma. And from the overall from these graphs that I have taken from here, Guinea, Liberia, and Sierra Leone lost over $2.2 billion in GDP, and fragile healthcare systems were overwhelmed. World Bank data, which is from the graph that I got these, which is the place where I got these graphs, shows steep declines in services, agriculture, and exports, setting development back years and leaving lasting social scars that still have yet to recover. So, CDC data shows three waves. Spring 2014, late summer peak, and early 2015 resurgence. Household secondary attack rates exceeded 50% without timely isolation. In many cases, spread before symptoms appeared. And epidemic curves and maps guided response timing and hotspot targeting. Response fatigue and flare-ups prolonged the outbreak. So, efforts included quarantine, isolation, contact tracing, and public education. The World Health Organization and MSF trained burial teams to ensure safe, respectful practices. PPE training and hygiene campaigns used visuals for low literacy audiences. Radio and music spread messages, and the WHO response charts how these efforts were linked. And trust building took months in many areas. So the RVSV ZEBOV vaccine, trialed in 2015, showed 100% effectiveness. A ring vaccination strategy helped contain the spread, and the campaign built lab and data infrastructure with mobile surveillance and mapping tools. This success informed future efforts in the DRC and shaped COVID-19 preparedness. So the outbreak exposed deep ethical questions. Who gets care when beds are limited? Should vaccines be prioritized for responders or the public? Community resistance to foreign health teams stemmed from cultural missteps and historical distrust. Burial restrictions were especially contentious, often perceived as disrespectful. So before the outbreak, most affected countries had fewer than 100 doctors total. ICU capacity was virtually non-existent and diagnostic labs were severely under-resourced. PPE shortages left healthcare workers vulnerable, especially in the early months. Basic public health tools like thermometers, gloves, or clean water were in short supply, and these infrastructure deficits magnified the outbreak's toll. So, global health organizations pledged over $3.6 billion in aid, with the WHO, MSF, CDC, and UNMEER, the UNMEER, coordinating efforts. The initial response was criticized for being too slow and fragmented. As the outbreak escalated, air bridges, mobile labs, and field hospitals were set up. The UNMEER organizational chart, as shown here, helped manage cross-border logistics, human resources, and technical assistance. Donor governments also face challenges in navigating bureaucratic restrictions. Despite the challenges, the multinational response laid groundwork for later reforms. So the world learned that early detection and culturally informed responses are key. Surveillance improvements now include rapid testing, solar-powered labs, and mobile data platforms. Trust is now seen as just as important as technology. One WHO retrospective declared the world was unprepared. And that painful lesson catalyzed reforms in global health security, including IHR updates and the founding of the Africa CDC. So this was the largest Ebola outbreak in history and one of the most instructive. It exposed global vulnerabilities, but also increased resilience, science, and innovation. Out of tragedy came progress, vaccines, and better protocols and global solidarity. The aftermath left West Africa with stronger surveillance systems and a generation of experienced outbreak responders. Today, those lessons remain deeply relevant as we face ongoing health issues across the globe. And these are my references. Thank you so much for listening.